When the surgical clamps are released, blood flow is restored to the newly anastomosed organ, causing the tissue to expand and flush with oxygenated blood. From reperfusion, allograft survival depends on a continuous struggle against the host's immune system. Graft rejection manifests as a spectrum of distinct hypersensitivity reactions rather than a single pathological entity. These reactions are governed by time, dividing the postoperative period into 3 temporal zones: minutes, weeks, and years. Each phase on this timeline identifies a different underlying immunologic threat to the graft. Pinpointing the exact timeline of dysfunction determines the precise surgical or medical mandate for the patient. Mastering this temporal axis is the foundational skill required to diagnose and salvage a failing allograft. The first temporal zone occurs within the minutes to hours window immediately following the anastomosis. Hyperacute rejection is a type 2 hypersensitivity reaction driven by pre-existing host antibodies. Preformed IgG antibodies immediately bind to the donor's endothelial surfaces, signaling the host immune system to attack. This binding triggers a violent activation of the complement cascade, leading to instantaneous platelet aggregation and microvascular thrombosis. Within minutes, the tissue aggressively shifts from a healthy pink to a mottled cyanotic state as blood flow is physically obstructed. Because the thrombosis is mechanical and widespread, pharmacologic rescue is impossible. Leaving the necrotic organ in place creates a severe risk of consumptive coagulopathy for the recipient. Hyperacute rejection carries a surgical mandate for immediate graft explantation while the patient is still in the operating room. The temporal axis then advances to the weeks to months phase, typically peaking within the first 6 months after surgery. Acute cellular rejection is a type 4 hypersensitivity reaction, which is distinct from the antibody-driven hyperacute phase. In this mechanism, recipient CD8-positive T cells aggressively infiltrate the interstitial space to attack donor MHC molecules. This cellular attack presents with a specific clinical signature: systemic fever, localized graft tenderness, and a rapidly rising creatinine. The diagnostic prerequisite for this phase is a biopsy confirming the presence of dense lymphocytic infiltration. Unlike the irreversible thrombosis of hyperacute rejection, this cellular inflammation is exquisitely reversible. Following diagnostic confirmation, acute cellular rejection dictates a medical mandate for initiating high-dose pulse IV corticosteroids. The final zone of the axis is the months to years phase of graft survival. Chronic rejection is a mixed type 2 and 4 reaction driven by CD4-positive T cells responding to recipient antigen-presenting cells. This interaction triggers a relentless, long-term release of inflammatory cytokines. Over time, active cellular inflammation gives way to the irreversible deposition of thick collagen matrices. Histology reveals organ-specific signatures: bronchiolitis obliterans in the lungs, accelerated atherosclerosis in the heart, and interstitial fibrosis in the kidney. This late-stage failure is distinct from the immediate cyanosis of the operating room, or the 6-week creatinine spike that responds to steroids. Because the structural damage is irreversible, chronic rejection dictates a mandate for supportive care or evaluation for retransplantation. To integrate these 3 mechanisms into a clinical context, we can evaluate a master case. Consider a 45-year-old male who is exactly 4 weeks postoperative from a renal transplant. He presents with a fever of 101.5 degrees, severe graft tenderness, oliguria, and a BUN to creatinine ratio of 30 to 2.5. Fever and localized tenderness often mimic infection, such as pyelonephritis or a post-surgical abscess. These symptoms may tempt a clinician to initiate empiric broad-spectrum antibiotics. However, mapping the 4-week timeline and localized tenderness leads directly to the acute cellular rejection pathway. Empiric IV ceftriaxone fails to address the underlying T-cell-mediated response dictated by this timeline. Similarly, immediate graft explantation is reserved for the hyperacute presentation seen in the operating room, not a patient 4 weeks post-op. Pharmacologic adjustments, like increasing maintenance mycophenolate mofetil or using plasmapheresis, do not provide the acute suppression needed for type 4 cellular infiltration. The required execution is to proceed immediately to a core needle biopsy of the allograft. Confirming the dense lymphocytic infiltrate via biopsy is the prerequisite for initiating high-dose pulse methylprednisolone. To salvage the allograft, you must master the timeline, isolate the underlying mechanism, and execute the required clinical mandate.